landscape. So short lang, before the Universal Healthcare Act, the salient provisions of the UHC and some updates specifically on local health systems and catch-up plans and call for action. So, when it comes to universal healthcare, actually baby pa ang ating bansa. But yung mga ibang countries, matagal na nagsimula ng kanilang UHC or termed as universal health coverage. So, this is the picture of the public health system before the UHC and possibly continuing up to this moment. So the Philippines exhibits slow improvement in terms of the health outcomes. So even though our life expectancy has been increasing, it is still lower compared to our neighboring countries. In addition, our country is already experiencing the triple burden of disease, wherein there are increased health cases related to globalization. So yung mga road accidents, and also the Philippines being the third country with the highest risk for disaster in 2018. But now, actually, we are ranked one. So meron naman tayong top one tayo sa country with the highest disaster risk. In addition, there are rising incidences of non-communicable diseases due to changes in lifestyle. But despite this, we still have a prevalence of communicable diseases, especially with alarming cases of HIV and tuberculosis. There are also inequitable distribution of health resources. Most of the hospitals, facilities, and health human resources are concentrated in Luzon and in urban areas, and of course, lowest in GIDA or geographically isolated in disadvantaged areas or rural areas, especially in Barm. So if this will continue, low-income LGUs be pushed more into poverty and equity gap will grow wider. We also have an unregulated private sector. So the Philippine healthcare system is actually characterized of having a dual system. We all know, baka nabanggit na rin po sa mga lecture nyo, that the public system is mainly financed by taxes, while in private sector, both for profit and non-profit, are largely market-oriented, and where healthcare is paid through user fees at point of service. So the DOH has limited mandate over the private sector except for some regulatory services. Hence, there is a need to maximize the collaboration of both public and private health providers in order to respond to the increasing needs of the population. Lastly, inefficient public spending on health, both by the national government and the local government units, especially in primary care. So there is really a need to invest more in primary care as it will be strategically cheaper to invest in health promotion preventive services for both sick and healthy population than spend for costly treatments and diagnostics when people are already sick. In addition, on focusing on primary care capacity of the LGUs would improve the primary care gatekeeping at the RHU or urban health center level, and the hospitals can focus more and improve their specialist services. So my next slide, alam kong alam na din ng lahat. Um, in addition, the Philippines has a fragmented health service delivery system. So this is from Section 17 of the Local Government Code, wherein you can see that the basic services, including health, that of health, are devolved to the local government units. So this is to endeavor LGUs to be self-reliant and to take over functions and responsibilities of national agency. So for the barangay, they are mandated to provide health and social welfare services, including maintenance of barangay health center and daycare center. While for the municipalities, they are mandated to provide health services, including primary care, maternal and child care, and communicable and non-communicable disease control services, also to provide access to their constituents when it comes to secondary and tertiary health services, the purchase of medicines, and also medical supplies and equipment for the facilities. For the provinces, they are mandated to provide hospital and other tertiary health services. While for the city, they shall provide all the services and facilities of both the municipality and the province. So this slide shows also the fragmented health delivery system and management. So the DOH, as you can see, has the oversight with its attached agencies and specialty hospitals and manages the Centers for Health Development or the DOH regional offices. DOH retained hospitals and sanitaria and drug abuse centers, while the provincial LGU manages the provincial health offices in the district or provincial city or provincial hospital, while the municipal LGU manages the municipal health offices, health centers, and barangay stations. So imagine if these LGUs are not in good terms with each other. So the primary care network is disconnected with the secondary and tertiary care services. So this would entail more costs for the patient in terms of consultation, laboratory, and transportation costs. Actually, kahit naman magkabate si mayor at si governor, hindi pa rin natin masasabi na currently that our primary care network or the current status of our primary care gatekeeping is already connected with the secondary and tertiary care services. So baka with some of the LGUs. But what the UHC envisions is that this would be available to all of the Filipinos. I mean, all provinces, all LGUs have this kind of complete and comprehensive services and affordable services within their network. So hence, for UHC to work, there shall be a good primary care system wherein primary care facilities are well equipped and adequately supplied with medicines. The primary care workers are competent and adequate in numbers. There shall also be an established referral system from primary care to secondary or tertiary to improve patient care and reduce costs for patients in repeating labs and images. And there shall also be adequate beds in every hospital, level 1 or level 2 within the province, and adequate specialty centers distributed throughout the country. So now let us go to the UHC Act. The UHC Act provides important reforms in the Philippine healthcare system. So I will focus my presentation with regards to population coverage, which answers the question who are covered, service coverage or what services are covered, and financial coverage or how much is covered. Basically, the focus of the UHC is to increase all the coverages and improve financial risk protection, to have better health outcomes and improve the responsiveness of the health system. So first, for the population coverage, we all know that all Filipinos are now automatically included in the National Health Insurance Program. In addition, the membership was simplified into two: the direct contributors or those who have the capacity to pay premiums, and in the indirect contributors and their dependents or whose premiums are being subsidized by the government. Even though automatic na ang inclusion ng lahat ng Pilipino sa PhilHealth, there is still a need to update their profile in the nearest LIO or in the nearest health facility. PhilHealth has already issued several policies regarding this automatic inclusion, and they have also a policy and guidance on how the social workers within the municipality or different LGUs can assess someone who falls between the category direct contributor or indirect contributor. So there is some form of an assessment para malaman kung yung mga hindi talaga, paano ba, hindi parang yung mga gray area, hindi sure kung direct siya or indirect, meron na rin silang policy for that. Next would be the service coverage. For the service coverage, everyone would now be immediately eligible to access population and individual-based health services, provided that the goods and services to be included shall be determined through a fair and transparent health technology assessment or HTA process. So, yung HTA refers to the systematic evaluation of properties, effects, or impact of health-related technologies, devices, medicines, vaccines, and all other health-related systems developed to solve a health problem and improve the quality of lives and health outcomes, and utilizing a multidisciplinary process to evaluate the clinical, economic, organizational, social, and ethical issues of a health intervention or technology. So, it is a recommendatory body to the DOH and PhilHealth for the development of policies and programs, regulation, and determination of a range of entitlement. So this include Philippine National Formulary System, the Essential Medicines List development, National Health Programs Clinical Practice Guidelines development, etc. So within 5 years after the establishment and effective operation of the HTAC, it shall transition into an independent entity separate from the DOH and attached to the DOST. So early in 2023, last March, it was already transferred to the DOS. Another aspect of the service coverage is for PhilHealth to develop a comprehensive outpatient benefit package within 2 years from the passage of the UHC Act and in accordance to the recommendations of the HTAC. Various reforms, further various reforms. Actually, itong COBP, dapat within 2 years, pero nakailang taon na. Medyo late na to. Though, nagmo-move tayo from dating PCB, naging expanded PCB, then Consulta, Consulta Plus, tapos Consulta SDG. So, currently, ang ini-implement ngayon ng mga primary care facilities ay Consulta, but the PhilHealth is currently piloting some financial provider payment reforms sa selected LGU so that they can test different reforms like itong konsulta plus SDG. So bago to, itong PhilHealth gamot, etc. So mamaya i-discuss ko kung ano yung mga pinapilot nila. So various reforms are being piloted by PhilHealth. This includes rollout of Consulta Plus SDG, so including sa SDG yung TB, HIV, animal bite, and malaria. So unti-unti na nilang pinapasok yung sinabi kong apat dun sa primary care benefit package. And modified capitation rate and PhilHealth gamot bago rin to, which aims to contract out private pharmacies to provide medicines. Mga bago to, magbibigay ako ng details mamaya. Sana hindi lang kayo maguluhan sa pagre-review kasi bago to, so baka hindi pa to na lecture sa inyo. This outpatient drug benefit package aims to expand service coverage through ensuring drug supplies by linking health facilities with the drugstores. We all know that one of the major causes ng ating high out-of-pocket expenditure sa Pilipinas ay pagbibili ng mga gamot. So, this is one of the interventions of PhilHealth in complying with the law, statutes of the law, na there shall be a comprehensive outpatient benefit package and emergency medical services. So the vision and policy directions of the DOH PhilHealth is to minimize out-of-pocket spending specifically for medicines and expand service coverage, ensure drug supplies through market creation, by linking health facilities with drugstores, and strategic inclusion of retail pharmacies to enhance service and financial coverage. So it is desired to have an outcome that with this benefit, drug benefit, it shall engage different pharmaceutical service delivery entities so that they can also be engaged within the healthcare provider network. And then eventually, this will form any results of the pilot tests, sandbox sites being implemented right now and next year. It shall form part of the COB, or the comprehensive additional feature of the PhilHealth Gamot. It has its own benefit rate and payment scheme. Yun, and eventually will form part of the COBB as a standalone outpatient package. So details from this may be provided more clearly if you have a resource speaker from PhilHealth. So another from service coverage. Health goods and services, we all know, must be classified as either individual-based or population-based to guide the DOH, PhilHealth, and LGUs and other stakeholders more on the appropriate financing mechanisms and the provision of such health services. So the classification process of health service package follow a set of criteria based on the economic concepts of public good, rivalry, excludability, and externality. Though we all know that some areas in health have are still in the gray area, so not sure if it can be classified as individual based or population based, and is still under study. The DOH has also issued a manual for primary care managers, has developed the integrated course on primary care, and has issued the omnibus health guidelines per life stage. So these are all produced by the Disease Prevention and Control Bureau. So the Omnibus Health Guidelines for Life Stage was made to help the health workers veer away also from focusing on health programs and in order to provide people-centered services. On the establishment of epidemiologic surveillance and response systems and mandatory reporting of notifiable diseases. These are all articulated in another law, which is RA 11332, and it's revised IR. So the Omnibus Health Guidelines per life stage are developed to serve as the overarching policy issuance in integrating various standards of care. So these guidelines shall provide the life course approach for the delivery of services appropriate to each Filipino and guide the functional and efficient linking of health services across different levels of care, different care settings, and across the entire spectrum of care, with primary care as the foundation and intersectoral participation as the key principle. So there are separate OHG per life stage, and these OHGs shall be updated every 3 years or as necessary based on the new evidence, new policy directions, and feedback. UHC also aims to strengthen health promotion and preventive services. Also, the DOH wants to redefine health promotion as not just providing IEC materials or having advocacy campaigns, but by ensuring the presence of healthy communities, healthy schools, and healthy workplaces through the Health Promotion Bureau. So health promotion initiatives shall be designed and implemented strategically in key settings to ensure that the environments wherein individuals live, learn, and work are promotive and protective of health. All health promotion interventions also shall be anchored on the following priority areas or risk factors: diet and physical activity, environmental health, immunization, substance abuse, mental health, sexual and reproductive health, and violence and injury prevention. Several health promotion playbooks were also developed by the Health Promotion Bureau to assist the LGUs in the implementation of health promotion interventions. Another slide for the service coverage. The UHC aims to provide every Filipino his or her own primary care provider. So when we say primary care provider, it refers to a primary care worker with defined competencies. So Health Human Resource Development Bureau meron na silang policy on the defined competencies for a primary care worker, but as of now it is still undergoing development. So for this is still for the physician, the nurse, and the midwife pa lang. Who has received certification to perform primary care practice in a licensed primary care and licensed and accredited primary care facility. So the primary care provider shall act as the navigator of care for the patient, initial and continuing point of contact in the healthcare delivery system. And every Filipino shall register with a public or private primary care provider of choice with due consideration to proximity and ease of travel. However, the health sector still has a long way to go since there is still a low percentage of Filipinos registered to a PhilHealth accredited primary care provider. Having only 15% of the population. In addition, although there are 412 facilities with at least one primary care worker team or 9,432 health professionals have been certified, provisional certification by the DOH, the numbers are still inadequate to cater the health needs of the population, especially when the certification is still limited to three cadres. The one I mentioned, physicians, provinces, there are also moreover, only 21% of the provinces have adequate number of primary care facilities or meeting at least 50% of their respective 2025 projected demand as stated in the Philippine Health Facility Development. For the financial coverage in terms of health financing, I think you have also a specific module for this and um, RP or reviewer for this. In terms of health financing, the UHC Act clarifies which services are to be paid for by the DOH, LGUs, and PhilHealth. So the DOH shall support the LGUs in population-based health services, while the PhilHealth shall support the LGUs and private providers in the provision of individual-based health. One new major reform in PhilHealth. Yes, sorry. Ito po, okay na po. Okay po, sorry. So one new major reform in PhilHealth is network contracting. So alam naman natin dati facility contracting sila, but per UHC law, network contracting sila instead of contracting individual facilities. So they shall be contracting public, private, or mixed healthcare provider networks for the provision of individual-based health services. These networks, however, should agree with PhilHealth on service quality, co-payment or co-insurance, and data submission standards. So, furthermore, the current PhilHealth support value is at 66%. This means that for every 100 peso of hospitalization costs, PhilHealth covers at least 66 pesos. Though this has increased from 2017, there is still a need increase its support value to reduce out of pocket costs for the patients. So a while ago, I have stated that one of the problems in the Philippine healthcare system is the fragmentation of health service delivery and governance brought about by devolution. So to harmonize the efforts and ensure efficient delivery of health services in public facilities, local health systems will be integrated into province-wide and city-wide health system. So these are the LGUs which have committed to integrate their local health systems into province-wide or city-wide. So they are currently called as the UHC integration sites. These health systems are to be governed by the provincial or city health boards and whom are mandated to. The provincial and city health boards are mandated to oversee and coordinate the integration and delivery of health services across the healthcare continuum for province-wide and city-wide health system. One moment, please. Also, the health board shall manage the special health fund and shall exercise administrative and technical supervision over health facilities and human resources within their respective territorial jurisdiction. Municipalities and cities that commit to health system integration are entitled for representation in the provincial or city health. So, since 2020, the DOH has engaged UHC integration sites, yung sinabi ko kanina, who which have expressed their commitment to integrate their local health systems into province-wide or city-wide health systems and have signed a tripartite memorandum of understanding with the DOH and PhilHealth to implement the integration reforms. They will endeavor to achieve managerial and technical integration in the first 3 years and financial integration in the next 3 years upon the enactment of the UHC law. So ano bang pagkakaiba ng managerial and technical integration? So managerial integration refers to the consolidation of administrative, technical, and managerial functions over the PCWHS over its resources, such as health facilities, HRH, health finances, health info system, health technology, equipment, and supply. So that's managerial integration, while technical integration, mas focus siya sa service delivery, functional and efficient linking of health service provision from primary to tertiary care and appropriate across different level of facilities, care settings, across a comprehensive spectrum of care with primary care as the foundation. So at the minimum, the managerial integration shall be characterized by the following: having an ordinance on the commitment to integration, unified governance, functional referral system, functional Dream Age, functional EPID system, proactive and effective health promo programs or campaigns, and integrated management system, including planning, health info system, HRHMD, procurement and supply chain management system, financing and quality assurance system. Whereas financial integration, on the other hand, refers to the consolidation of financial resources exclusively for health services and health systems development under a single planning and investment strategy, or the LIPHAOP, by the PCWHS. At the minimum, financial integration shall be characterized by the following: the creation of the Special Health Fund, a whole health board resolution on the Special Health Fund use, and funds exclusive. These funds are being used exclusively for health and health related needs. So in the end, the main goal is to achieve a public-led healthcare provider network wherein there is an established primary care provider network for primary care concerns, wherein services or goods not found in the PCF are sourced out or contracted out with a private provider. There shall also be a level 1 or level 2 hospital and level 3 hospital within the network, and established two-way referral system from the primary care to higher level providers. So this shall be made possible through interoperable electronic medical records or system rather, and establish local referral mechanism. And lastly, an HCPN with matched Apex Hospital, which is a single specialty or multi-specialty hospital. So this is the dream, the vision of UHC. I just want also to reiterate that universal healthcare is not a program, rather it is a way of life or a destination that we ought to achieve. So, katulad din na nababanggit sa batas, it is a progressive realization and there are still many moving parts, but yun, itong pinakagusto natin and what we want to be experienced by everyone, especially ng ating mga relatives na um, the services are complete within the network, no need to repeat different labs. All data are being shared by the different providers within the network. If not free, the services shall be affordable and provided by competent and adequate and with appropriate skill mixed healthcare workers. This slide just shows you the breakdown of the integration sites per region. Currently, we have 74 UHC integration sites. So, this is a combination of provinces, HUC, and ICC. Before August 2023, we only have 71. Actually, in 2020, we have 58. And then there's an additional 13. And then last August, Taguig and San Juan City were approved. And Occidental Mindoro, I think, papunta na rin doon. May konti na lang na inaantay. So, this is the UHCR. So, yun muna. Itong LHSML na to ay pang Region 6 siya. So, magpalit lang ako saglit ng slide. So, share. Okay pa naman kayo? Discuss ko lang mabilis yung SHF. So, 2022 slide ko pa 'to na SH. So, katulad ng binanggit ko kanina, the DOH, DILG, PhilHealth, and LGU shall endeavor to integrate health systems into province-wide health systems. Those that which have committed shall ensure managerial and financial integration and provide the needed resources and support mechanism to make the integration possible and sustainable. And for those which have committed, for the first 3 years upon the enactment of the law, at the least they shall exhibit managerial and technical integration, and then for the another 3 years, they shall exhibit financial integration. So the reason why after 6 years ng enactment ng law, there shall be an independent study to be commissioned by the JCOC or the Joint Congressional Oversight Committee for the UHC, and then it will study or assess the viability, feasibility, and the benefits if there are overall benefits in LHS integration, and if there will be positive recommendation from the study and also positive recommendation from the Secretary of Health, then all local health systems shall be integrated through the issuance of an executive order by the President. So, very important right now, aside from the complying with the different MOVs for the local health systems maturity level, both for the managerial, technical, and financial integration, one of the important things to do by everyone, not just by the LGU, but also by the development partner, the regional offices, and the national offices, ay documentation of different successes, pwede rin hindi successes, small failures, troubleshooting, and how did you arrive to a better solution so that the other LGUs could also adapt what's applicable to them. So very important ang documentation, especially during this phase that we are piloting different reforms. Done. Done. So for the Special Health Fund, as I have said, this is a pool of financial resources intended for health managed by the province-wide and city-wide health system. So, just to ensure more strategic and efficient pooling of resources, to reduce fragmentation of health, promote integration, and improve equity, provide appropriate incentives and financing mechanisms to achieve and sustain integration, and ensure transparency and proper accountability on the use of health resources. So, just a brief background. Currently, we have two types of funds, the general fund and the special fund. So, the LGUs who are with us today are familiar of this. So, in general fund, it is used to pay for expenditures, obligations, or purposes not specifically declared by law as accruing and chargeable or payable from any other fund. Release of funds from the general fund is subject to the appropriation ordinance from the sanggunian concerned. On the other hand, the special fund consists of monies and resources used to pay for specific purposes and are considered automatically appropriated for purposes indicated therefore. So currently, before the UHC Act and under the Local Government Code and its IRR, we have two existing special funds, the Trust Fund and the Special Education Fund, which are created at all levels of the LGU. Under the Universal Healthcare Act, a third type of this special fund was created. This is the Special Health Fund, But unlike the first two types, the special health fund shall only be created at the level of the province and highly urbanized or independent component city. And also, this is still being implemented right now by the UHC integration sites. So the provincial or city health board must assume the full responsibility in the management of the special health fund. They must ensure that the SHF is optimally utilized to help achieve the desirable health outcomes of the population within their respective territorial jurisdiction. Given this responsibility, the provincial or city health office will act as the board's technical secretariat, while a management support unit shall be created to assist the board in administrative or related concerns. The provincial or city health board, together with their technical and administrative secretariat, must closely coordinate with their provincial or highly urbanized city or independent component city budget officer, provincial treasurer, accountant, treasurer, and other concerned offices in the component LG. This slide illustrates the different sources of funds for the special health fund. So first we have ito yung mga sources of funds na pwedeng pumasok sa special health fund, the financial grants and subsidies from the national government agencies such as the DOH, so which will be transferred to the special health fund using the terms of partnership. Second, the income from PhilHealth payments, which will be transferred after the signing of the SLA. Actually, in majority or 95% of the funds that will be coursing through the special health fund will be coming from PhilHealth. Third, we have the donations and financial grants from the CSOs and international health partners, which can be facilitated through the use of a memorandum of agreement. Moreover, we have other fund sources which may also include LGU budget for health. So this is an optional source for the special health fund. So this is not a mandatory source. Transfer of funds will be facilitated through a memorandum of agreement as authorized by the Sangguniang concerned. Please be guided that the pooling to the special health fund of LGU budget for health is not mandatory, but counterpart funding or resources for health shall be provided by the LGU. So this illustrates ito naman sa kanan yung mga allowable expenses for the special health fund. Population-based health services, environmental health services, health promo, disease elimination, EPID, and preparedness, allowable expense, individual-based health services, ambulatory inpatient care, purchase of medicines, lab tests, and procedures, health systems operating cost, support to health system management, learning and development interventions, fees for accreditation and licensing, conduct of trainings, seminars, conferences, or convention, gasoline for vehicle use for service delivery, commodity, and specimen transportation. Capital investment, health infrastructure, health equipment, instrument, ICT, ambulances, PTVs, mobile clinics. Remuneration of additional health workers may be sourced from special health fund until such time that the LGUs have implemented incremental creation of plantilla positions to hire the required number of healthcare workers based on the standards determined by the DOH. Incentives for all health workers, including the barangay health workers and barangay nutrition scholars, within the territorial jurisdiction of the province or city health board will be decided upon by the concerned. expenses chargeable against LGU mandatory counterpart fund. So, ito yung mga hindi pwede sa special health fund. Mandatory expenses of health facilities, office, and services, remuneration of existing human resources for health personnel and those under civil service position, physical office and administrative expenses of the concerned health board and its MSU, land acquisition and development for the construction or upgrading of health facilities and services. So the next slide would be the general steps overview ng Special Health Fund from creation up to monitoring. So a special health fund depository bank account must be created in accordance with the existing Department of Finance, Bureau of Local Government Finance guidelines. So may guidelines ang DOF, BLGF on authorized government depository bank accounts and other relevant issuance. A separate SHF book of accounts must be created and maintained at the province or HUC or ICC levels. Subsidiary ledgers must be created for each identified fund source. And if funds will be transferred to the component LGUs from the SHF, these funds must be transferred to the trust fund account of the component LGUs with a subsidiary ledger created for this purpose. So the provincial or city health board, so after makreate yung bank account, then planning and budgeting, the provincial city health board through the provincial city health office and with the assistance from the CHDs will facilitate the formulation of the annual operational plan. So supposedly, before this, you should know the LGU how much yung estimate na makukuha nyo from the different sources. Like how much yung makukuha sa PhilHealth, sa DOH, and if may other sources pa kung merong mechanism for pooling at the component LGU level. So, the LIPH and AOP will serve as the basis for the health boards in the planning and budgeting for the special health fund as well as for the contractual arrangements with the DOH and PhilHealth. Provincial or city health board resolution on the SHF budget must be deliberated, endorsed, and approved by the chairperson, vice chairperson, and a majority of the members of the provincial or city health board. To uphold the fiscal autonomy of the LGUs, the joint memorandum circular on the guidelines on the allocation, utilization, monitoring, and accountability for the special health fund did not prescribe a specific allocation criteria. So the JMC, the Joint Memorandum Circular on Special Health Fund that I have mentioned, is a joint policy amongst different agencies, including the DOH, the Department of Finance, the Department of the Interior and Local Government, the Department of Budget and Management, and PhilHealth. Disbursement and utilization, PCHP. So in addition to the existing government budgeting and accounting and auditing rules, disbursement from special health fund will be based on first, the allowable expenses chargeable against the SHF. Second, the LIPH and AOP. And third, the contractual arrangements of the provincial or city health board. With the DOH, so for the DOH, the terms of partnership. With PhilHealth, so for PhilHealth, the service level agreement. And with the CSOs and international health partners. With your corresponding MOAs as applicable. And the provincial or the city budget treasurer, officer, and accountant must be provided with a copy of the approved health board resolution on SHF as basis for the certificate of availability of funds, disbursement, and recording. The authorized signing officials of the disbursement of funds will be in accordance with the local government code in the UE. So, the provincial or city health board will furnish copies to DOH and PhilHealth through their respective regional offices of the LIPH, AOP, and Provincial Health Board resolution, containing, among others, the expenditure items to be funded out of the Special Health Fund. And the DOH and PhilHealth must establish and maintain SHF utilization system to allow real-time collection, consolidation, and analysis of the data on the use of such fund. So, with regards to the monitoring of the SHF, the Department of Finance actually has its LIFT system or the LGU Integrated Financial Tool System, which is ito yung system na currently ginagamit ng mga LGUs to track their expenditures. The statement of statement of receipts and expenditures, yung mga expenditures ng LGU, including that of health. So DOF has included already an SHF module within their system, and this will be piloted to the LGUs which are currently implementing the SHF. But the pilot and training still to be discussed with the Department of Finance. So that utilization of SHF, whether willfully or through negligence for the disallowed expenditure items, must subject the erring provincial or city health board and local government officials to penalties under existing laws and regulations. The monitoring of the utilization of the special health fund must allow existing and accounting must follow, existing accounting and auditing rules and regulations. So these are just the forms to be used in budgeting, planning, monitoring the special health fund. These are also annexes of the JMC 2021-0001 or the guidelines on SHF. Yes, may hinahanap lang. Sorry, ang dami May hinahanap lang ako pero siguro yung mga iba pwede nang if may question at kung kaya ko namang sagutin, pwede ko namang sagutin.
Thank you for the lecture, Dr. Kath. I would just like to clarify on the implementation of the Omnibus Health Guidelines since the Omnibus Health Guidelines are out already. Is there a timeline of its implementation as this will really address our concern on the programmatic approach of our strategy implementation? Thank you.
Thank you, Ma'am Melanie. Based on my latest update, as far as I have known, the DPCB is currently drafting an implementation tool or somewhat to operationalize the OHG, the Omnibus Health Guidelines. Also, some of the developments, as I have said, di ba meron tayong, ko, sige, sasagutin ko yung tanong mo habang mag-share ako ng additional information. Sana po hindi kayo ma-info overload. Is my currently DOH and PhilHealth out of the 74 UHC integration sites ay nagpa-pilot ng different PhilHealth reforms into selected sites which most likely more advanced in terms of managerial and technical integration to test financial integration na. And one of the interventions na tinitingnan ni DPCB as the one have issued the Omnibus Health Guidelines is the creation of case management pathways, not just for a specific disease or intervention, but on how this OHG would be operationalized from the primary care to across different care settings to secondary or tertiary care. So they are ito yung isa sa mga kumbaga ipapilot nila sa mga sites. Yan. So, ito yung sinasabi kong mga current interventions or pilot right now. So, we have the integration sites, the 74 which I have mentioned. There is somewhat what we call the PCP and the primary care provider consulta sandbox as initiated by PhilHealth to pilot prospective payments for consulta primary care provider network. So, ang pinapilot dito ay prospective payment ni PhilHealth sa konsulta sa primary care provider network, meaning hindi pa kasama yung hospital, and the HCP and demo sites kung saan kasama na yung hospital. So dito sa HCP and demo site, dito ita-try kung paano i-operationalize yung case management pathways for the OHG. Yun po, hopefully nasagot ko yung tanong mo. But additional updates is best heard kay DPCB po. Thank you.
Thank you po, Doc Kath.
Thank you po sa question. Actually, ang gusto sana natin, 'di ba, all healthcare providers are looking within the same set of standards of care. Pero with the limitations right now on the availability of the different implementation tools, as set of course by the DPCB, and on how we can apply those in various settings, since hindi pa siya gano'n kalinaw or ka-concrete kung how to operationalize the OHG. Sa ngayon baka hindi pa siya talaga ma-implement ng lahat. But the vision is we're looking at just one set of standards of care. Yun po. Thank you. Mabilis lang 'to. Sorry. Ang dami kaya ako po natanong din kung paano ba 'to, baka maguluhan kayo sa review niyo kasi maraming ganap po. Gusto ko lang din banggitin na currently, eto na yung mga special health fund guidelines. Katulad ng sinabi ko kanina, yung Joint Memorandum Circular ng 2021, naglabas din ng DOH ng interim guidelines ngayong last 2023, mga May. And COA has already issued a accounting and reporting guidelines for the special health fund for the province-wide and city-wide health system. It was already oriented to the different CHTs. Kasama dito yung LIPH coordinator, planning officer, and finance team ng CHD. Kasama rin yung COA ng mga CHD kasi ako resource person namin dito noong July ay COA from national office din. Sorry. So ang aim ay since these guidelines are oriented to the CHDs, whenever the regional offices orient the special health fund to the local government units, their RPs should always include um, the COA from the region, the DOF from the region, and of course, kung kaya nila ma-invite both the PhilHealth and the DILG. Because as you can see, dito mo talaga makikita na hindi lang talaga health ang kasama sa UHC. Si DOF, important siya for the tracking of health expenditures because it owns the lift system of the LGU, and also on the authorized guidelines on the authorized opening of the different depository bank accounts for the DOF. For the DILG, of course, since there will be, for sure, there are several issues that may arise when it comes to the allocation of the special health fund because this is upon the prerogative or discretion of the provincial or city health board, the ILG, and the COA for the accounting guidelines and the accounting reporting guideline, recording guidelines, and the DBM, of course, help for and from the LI patient, the AOP. Current status of the local health system's maturity level as of mid-year last year, there are 19 UHC integration sites who had achieved at least 70% of the organizational level KRA. So we are currently finalizing the annual report for 2023. And last year, as of August or September 2023, there are actually 34 integration sites who have opened the Special Health Fund depository bank account. So, katulad ng sinabi ko kanina, PhilHealth has two sandboxes, current sandboxes right now. The PCPN sandbox and the HCPN demonstration project. So, the PCPN sandbox, these are their guidelines. So, these are the for the HCPN demo project, the most recent sandbox of the PhilHealth. Ito yung mga i-implement nila, the prospective payment or payment, hindi siya reimbursement. So, babayaran ka na at the start pa lang ng taon based on your commitments based on the target implementation. Network contracting, Consulta Plus, SDG PhilHealth Gamot, and ACR Global Budget. May nakita po ako, sagutin ko na, nakita ko nag-pop up yung question. What is a sandbox? A sandbox is like a pilot implementation. So, actually, the UHC integration sites are what we can also call them pilot implementations since we are piloting the integration reforms. So the tool for the UHC integration sites, the LHSFL, helps the LGUs achieve different incremental progression across the LHS maturity level. So we aim to achieve managerial, technical, and financial integration through the use of the LHSML. Last last year, 2022, 2023, PhilHealth initiated this PCPN Consulta Sandbox. They are also integration sites, but PhilHealth want to test its prospective payments. So, to this primary care provider network. So, ang aim niya is this to see and enhance horizontal integration. So, dalawa lang yung ang tinetest ni PhilHealth dito, the prospective payment and the PCPN. Prospective payment na dadaan sa SHF and the PCPN, the primary care provider network. Currently, the HCPN demo sites na ngayon ay inaayos din with PhilHealth and DOH. Ito talaga yung gusto natin makita, to simulate an integrated province-wide health system with PhilHealth payments to the SHF as the primary incentive. So ang mga itetest dito aside from the prospective payment, meron silang computation si PhilHealth dito. Network contracting, so meaning hindi lang primary care provider network, but pati buong healthcare provider network ang iko-contract. But of course, since this is a pilot, there are still limitations on whom or on which they can contract. Consulta Plus SPG, katulad ng sinabi ko kanina, yung tip ng mini-merge yung mga different OPD packages or benefit packages. So itong Plus SPG, ito yung TB, malaria, animal bite, and HIV. PhilHealth Gamot, and PhilHealth ACRGB. According sa law, supposedly, dapat DRG na i-implement ni PhilHealth. Pero tinatry mo na nila yung transitioning to the DRG. But they will already use the global budget for this. Actually, all of the explanations po nitong mga reforms nila ay better kung PhilHealth din ang mag-discuss since iba din po yung language nila when it comes to financing. Lang po, may nakita akong question. And ang gusto po natin dito sa HCPN demo site ay kasi sila na yung more advanced in terms of managerial and technical integration in terms of the management system, in terms of the governance. But still, we cannot achieve the real integration without financial integration. So, titignan kung paano sila mag-operate ng SHF, kung through PhilHealth prospective payments ng within the network, paano nila magagalawin yung isang integrated healthcare provider, isang integrated PCWHS. So it's more of a study and pilot ng mga PhilHealth provider reforms. Ano ko mo? Ko lang makita yung isang question. Ayun po, sana si Ma'am Maita nasagot ko kung ano yung sandbox. Si Ma'am Risa, Doc Riza, magkaiba po ba ang konsulta package ng OPD ng hospital? The konsulta package. Siguro po mas dapat po ito masagot ng PhilHealth, pero kung same lang po yung standard nila, I think hindi naman po magkaiba. Marami lang versions ngayon ng konsulta. Like yung konsulta SDG, parang version 2.0 na yon. So, baka may makita kayong konsulta, konsulta plus, konsulta 2. So, yun kasi yung parang mga versions ni PhilHealth kung paano sila mag-move towards comprehensive outpatient benefit package. Ano po yung mga tanong po pang PhilHealth. Ita-try ko pong sagutin yung mga alam ko lang po, pero sobrang basic lang po, pasensya na. Difference ng DRG at yung present scheme ni PhilHealth. Yung disease-related groupings po ni PhilHealth, ay ng DRG, actually DRG na pong ini-implement daw sa ibang bansa like Thailand, I think. Sa DRG, mas onte yung kailangan nilang i-update. Parang ilang libo kasi kapag sa hindi DRG, kung all case rates, maraming laging i-update. So, pag maraming silang masyadong i-update na cases, napag-iiwanan yung iba. Sa DRG, i-group nila yung mga similar cases and pag-aaralan kung paano ito-cause yung similar cases. At alam ko, may mga consideration na ang DRG when it comes to ano yung comorbidities ng patient. Parang mas responsive siya sa pasyente. Parang gano'n po, layman's term. Sorry, hindi ko talaga alam kung ano yung specific na difference nung all case rates sa disease-related disease. Pero yun po yung pinakasimpleng, ano, discussion. Discussion. 'Yun po yung pinakasimpleng, ano, 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 discus Thank you, Ma'am Maita. According to PhilHealth, pareho lang daw po yung consultant. Ayun po. Siguro mabilis na lang. Sorry, ang dami kong hanash. Last na lang, same problem. For health, yung latest natin for 2023 to 2028. And hopefully, it can guide us. Meron din kasi yung mga strategies on how to operationalize this 8-point action agenda. But I think medyo malawak pa rin yung mga strategies doon. So, just showing you the slide on how we can move forward. The health sector 8-point action agenda from 2023 to 2028 would really be focusing on the welfare and wellness of each and every Filipino citizen and community well-being, and of course with priority on our own health workers and health institutions. Eto lang po yung mga different strategic interventions na ang alam ko kailangan pa rin nating mas detalyehan pa kasi medyo malawak pa rin yung strategic interventions. But rest assured that the priority of the administration talaga ay primary care. Kasi yun yung dama, yun yung kahit na maayusin natin lahat ng mga sinasabi ating special health fund, local health system maturity level, hindi naman yun alam ng citizen, ng normal citizen. Ang alam niya, may gamot ba sa RHU? May tao ba sa RHU? Pag lumipat ba ako sa hospital, paano? Nandun na rin ba yung labs ko? So, yun yung gusto natin, that bawat Pilipino ramdam ang kalusugan in whatever form, whatever care setting may be. Gusto natin ligtas, de kalidad at mapagkalingang serbisyo at teknolohiya. Sa panahon ngayon, kailangan na nating sumabay with the very large data. We need to uh, filter out ano yung mga kailangan natin for policy development, for implementation and improvement. And paano natin i-maximize yung mga digital health technologies. Hopefully that the we can have good health information system, not just the use of the electronic medical records, but the use of health information system to monitor supplies. The procurement and supply chain management system can also be incorporated there, and also monitoring, of course, our facilities and our HRH within the facility. Handa sa krisis, sabi ko nga ang Pilipinas ang top 1 sa the highest disaster risk or prone sa disaster. So, kasama to sa mga priority agenda. Pag-iwas sa sakit, addressing social determinants of health and improving healthy behaviors. And the strengthening intersectoral action and health promotion governance at levels. Ginhawa, mental health, ginhawa ng isip at damdamin. So, isa to sa mga priority agenda ang mental health. And of course, for all health workers and protection from any potential pandemics, and to help recover from disease outbreaks. And humanistic leadership and good governance. So this is the strategy map for the 8-point action agenda. Yun po. Sana po may natutunan po tayong lahat kahit short lang at konti lang yung mga nai-share ko po dito. Thank you. For Dr. Riza and Ma'am Maita, actually, personally, I agree that medyo may conflict primary care when it comes to the hospital, especially when punta kami sa Isabela ba yun? Sa Region 2 na it's very difficult for the district hospitals to do first patient encounter since they do not have manpower like what the RHU or the municipal health centers have like the BHW. But PhilHealth said that for the meantime, since wala kasi talagang kulang na kulang pa ang konsulta accredited provider. Pero I do not know lang kung ano yung magiging direction nila sa future kung paano. But at a policy point of view, medyo maka-disrupt lang siya ng referral. Kasi supposedly, primary care shall be provided at the level of the municipal level. Ayun, ayun po. Mamaita.
Yes po, Doc. Actually po, nung nagdi-discuss kayo, parang nire-review ko din lang po yung process namin sa region, which is tama po, yun yung mga basis. And then, if I remember and understand right po, yung sa PCF po, ito po kasi di ba yung paulit-ulit natin sinasabi na dating tinatawag nating RHU na ngayon dapat PCF na po. Naalala ko po kasi, kaya yata po ang hospital, they retain the consulta package kasi po, nangyari po, nagkaroon kami noon ng directives po na to license all RHU as PCF, and then yung required na services po, kasi di po ba pag PCF dapat kumpleto na siya. May laboratory, may x-ray, may pharmacy, na license din po dapat. So dahil nahihirapan sila, ang nangyari po, we were required to license them. Tapos MOA-MOA na lang po yung mga services na yon. Tapos supposedly po noong 2023, nag-expire na yung moratorium for the MOAs. Dapat may sarili na po talaga sila. However, in-extend po yung moratorium, Doc. I don't know kung alam niyo po yun. So, in-extend na naman po yung moratorium. Kaya po namin din nalalaman sa program. Kasi pag umiikot din po kami, we were expecting na after the moratorium, available na po dapat yung services. So, kung tutuusin niyo po, they are licensed as PCF, pero hindi naman talaga available yung services po. So, yun po yung argument ng mga hospitals and yung mga pasyente din po na they prefer to go to hospitals kasi mas complete yung services niya for a PCF. Yun lang po, Doc. Thank you.
Thank you, Ma'am Maita, for the insight. Actually, hindi naman ako sa ngayon sa kalagayan, of course, ng PCFs natin. Hindi ko rin naman talaga masabi na kung bakit nagkakaroon ng primary care package sa hospital. Kasi sabi nga din ng PhilHealth, kulang na kulang pa rin yung mga primary care providers na accredited nila. Parang ganun po. Hindi ko lang sure kung ano yung magiging policy directions nila once na halos na masaturate na ng mga LGUs yung accredited primary. Thank you. Thank you everyone. Good luck. Good luck sa inyong exam. Sure po. Opo. Thank you.
Hello, good afternoon, everyone. I'm happy to see you all na sumasama sa mga review sessions and engage participatively sa ating mga resource persons. I hope na nare-refresh naman kayo, na prepare para sa inyong compre on the 16th, no? So we will see each other face to face soon. I'd like to add siguro dun sa explanation ni Doc Kat sa Sandbox. Having worked with PhilHealth while I was in the HPSDT office then, when the when the Consulta Sandbox was conceptualized by PhilHealth. So, I'd like you to imagine the sandbox mismo sa playground, yung mga bata. There's a box there full of sand, and the kids are allowed to make anything out of it, no? Mold the sand into something that they like. Nandun na lahat ng kailangan sa sandbox. Kailangan lang nilang i-model into something that they want. So, a sandbox is a step back from a pilot. So, sa pilot, meron ka ng set of guidelines, proof of concept, na gusto mong ipa-implement para scale up later on. So how the PhilHealth, actually I search up on it, the sandbox approach was first used in the IT industry kasi loose pa yung regulatory controls dapat sa isang sandbox area, no? So what you actually want to test is a policy or a mechanism or a strategy uh where the existing policies are slightly let loose for us to come up with models right after that can be used either to pilot or siguro scale up na right away. So for the Consulta Sandbox, no, nagsimula sila sa PCPN because if they start with an HCPN, the money is too big. So sinimulan nila doon muna sa PCPN at anyway, yun din kasi ang mas feasible at that time na implement. Mas marami ng PhilHealth accredited primary care facilities. So nag-start sila din sa primary care approach din, kaya naging sandbox. So what I'd like to drive is that the sandbox is a step back from a pilot implementation, and supposedly the regulatory controls in a sandbox are more loose than when you pilot something. So I hope naka-add naman dun. Kasi nung inexplain sa amin ng PhilHealth yan, nahirapan akong intindihin so they explained it to us in a way na talagang imaginein mo yung sandbox sa playground ng mga bata. No? So if you have any more questions, you can just type them in the chat box. We'll try to get the answers from the relevant offices. So maraming nasagot si Doc Kath kanina tungkol sa OHG na para dapat can be better explained by DPCB, sa ating health financing that can be better explained by PhilHealth. You can type it in and we can ask the relevant people to explain further. Try naming ihabol bago yung compre exam. But I'd like to reiterate yung sinabi ni Doc Quen kaninang umaga the concepts for the compre exam has to be understood and explained siguro gamit yung lens nyo where you are at the moment kung si anong level ng governance kung nasa region, province, municipality. So, thank you po. I see Ma'am Maita nag-comment. Thank you po. So, we'll stay on and wait for Doc Ruth. You can have a bio break. Doc Ruth, the Division Chief of Policy and Standards Division, will come in at 3 o'clock. Doc Kat, nakita ko nandyan ka pa pala. Thank you so much po, Doc Kat.